So we're going to look at this picture of the right coronary artery, and ultimately it's going to supply the posterior descending artery and the right marginal artery. So posterior, we know that that's going to be behind the heart. The right marginal artery is what supplies the right ventricle, and then when an inferior wall MI is identified to a right-sided 12 lead, this occurs to attempt the identity of the occlusion that's happening in the posterior descending artery, point A, which would be here. Or if it's happening at a proximal right coronary artery, point B, which would cause infarctions of both the inferior wall and the right side, right ventricle. When the right ventricle is involved, we are concerned with preload and nitroglycerin administration. So here we have the superior vena cava, your aorta, that's your right atrium, right coronary artery, posterior descending artery here, which is what we were looking at, which would lead into the right marginal artery and right ventricle. When a RVI is found, we're going to use caution with nitroglycerin. Instead, we're going to consider fluid bolus to support the aspirin and oxygen, support preload with aspirin and oxygen. Now, if we're looking at bundle branch blocks, there are two major main bundle branches in the heart. You have right and left bundle branch block. The left bundle branch block further divides into the left anterior fascicle and the left posterior fascicle. But we're not going to dive too far into different fascicles as far as it goes. The bundle branch block can be identified on the 12 lead, and I went over this, struggled with this in my cardiology section. And they're important to rule in and rule out. So they mimic or hide certain 12 lead findings. So here's a simple way to identify the bundle branch block, to stick to the turn signal method. So we're going to look in V1. It's important to remember, look at the QRS, see if it's wider than 12.12, fat and sassy. And if not, then you can stop. If it is, proceed to step 2. So we're going to check, see if it's wide first in which one was this? Yep, V1. With a wide QRS in V1, you need to know to determine if the QRS complex is deflected up or is it down. So picture yourself holding a steering wheel. If you're going to make a right turn, you hit the turn signal lever up. QRS is the wide and deflected up is a right bundle branch block. So QRS is wide, this is wide, and if it's deflected up, bundle branch block. Now you're going to make a left turn, so you hit the turn signal lever down. A QRS that is wide and deflected down is left bundle branch block. Right, I haven't heard of that before. I like that. So let's see what we got. Left bundle branch block, 12 lead interpretation is left bundle branch block, and then treat your patient clinical presentation. So 12 lead finding in right bundle branch block, however, you're going to treat in 12 lead findings. Treat your patient's clinical presentation and 12 lead. So left bundle branch, just treat the clinical findings. Right bundle branch, we're going to treat the actual heart itself. So let's look at this picture. V1, wide, yeah, that's definitely wider than 3 boxes. It's almost like 5, I want to say. I'm assuming this spikes up. That's got to be kalemia, the potassium. So it's wide and it deflects down. This is left bundle branch block. If it was, no, up. Up is right, down is left. Yeah. Okay, so advanced cardiac life support. Thought I was going to go into more information. So there's a few different medication dosages that you're required to know. So this is in ACLS and PALS that we talk about this. The medication and their dosages are on the American Heart Association guideline. Therefore, nationally recognized, accepted in practice. So whenever we teach ACLS, we find it easiest to do the breakdown, most of all cardiac rhythms, into either slow, normal, or fast, or dead categories. So with this approach, it really makes the light bulb go off for paramedic students. Slow, we have sinus bradyia, we have junctional escape, we have second degree type 1 and second degree type 2, third degree. Each one's getting slower and slower until we get to idioventricular, where it is strictly in the ventricles at this point. So let's divide them into two different categories based on treatment that would be most beneficial. So we have sinus bradycardia, junctional escape, and second degree type 1. If it is any of these, we're going to give atropine, 1 milligram, up to a max of 3 milligrams of atropine. If they are unstable, we're going to skip to electricity, and that would be transcutaneous pacing of 60 beats per minute minimum. AHA recommendation, increase is needed. We're going to start at 50 plus milliamps and adjust until mechanical pulse and electrical capture pacer spike is achieved. So right at the point where the QRS happens, you're going to see that pacer spike. You want to move it all the way to where that Q begins on the QRS. And we're also going to palpate and feel a radial pulse and make sure we can feel the mechanical pulse. Those two together is going to determine if our transcutaneous pacing has succeeded. Vasopressor for infusion. So once we've done this, now we're going to make sure their blood pressure is up. We're going to use vasopressor, and that would be dopamine, 5 to 20 micrograms per kilogram per minute that we're going to give, or epinephrine 2 to 10 micrograms per minute. If you wanted to be safe, I would say 10 micrograms of either per minute, per kilogram. Oh wait, okay, so epinephrine, there is no weight. So yeah, just memorize both of those. Second degree type 2, third degree, and idioventricular. These are more dangerous rhythms that could take someone out. So transcutaneous pacing, we're going to skip the atropine. We're just going to jump to transcutaneous and then do vasopressor infusion. As far as normal heart rates, we want you to be flexible. Some of the rhythms, not necessarily normal, but if we have a patient in the back of the medical unit, yeah. Okay, so we have normal sinus tachycardia, atrial fibrillation, atrial flutter, accelerated junctional, and junctional tachycardia. So treat the underlying problems, but we're not going to adjust anything to do with the speed or rate of the rhythm. Now, if we have fast heart rates, this is over 150, then we want to further divide the fast rhythms into stable or unstable. So there's supraventricular tachycardia, SVT, which means it is above the ventricles, whatever's happening, that's happening. And then there's ventricular tachycardia with a pulse. That's whenever everything that's happening is in the ventricles. And that's going to determine which medications we use, such as adenosine. Remember, when treating the fast rhythms, we have to determine if the patient is stable or unstable, if they're breathing, if they have altered LOC. So stable, alert, oriented, no significant complaints, hemodynamically stable, if they feel weak, lightheadedness. Unstable, they don't know where they're at, they have chest pain, difficulty breathing, disoriented, yeah. So we have stable SVT, we have vagal maneuvers. This is what we're always going to go to first. 1 out of 4 shots that this is going to work before anything else does. It's not bad options for being the least invasive. And then we're going to give adenosine 6 milligrams, rapid IV push, and then we're going to push after that 20 milliliters of normal saline. And then if that doesn't work, we'll do it again, but we're going to double the dose to 12 milligrams. So at this point, in total, 18 milligrams. And I'm not sure what the time limit is on that. I have to look at that. If they're an unstable SVT, supraventricular tachycardia, electricity, synchronized cardioversion, and we have our life pack instead of the Zol, so we will adjust it to 50 to 100 joules, 200 joules, 300 joules, maxed out at 360 joules. May consider sedation prior to cardioversion, again, depending on how aware of what they know is happening, if we're going to sedate them. Stable ventricular tachycardia, we are going to give amiodarone. So because this is happening below the atria of the heart, that's why it's going to determine whether we use adenosine. Adenosine is above the heart, amiodarone is going to be ventricular, below the heart. So if we have stable VT, we'll give 150 milligrams over 10 minutes. And amiodarone is pretty dangerous. Procainamide, 25 to 50 milligrams per minute. And then solutol, 100 even. Or 1.5 milligram per kilogram over 5 minutes. My understanding was 100. Yeah. So if it's unstable, skip medication, go to electricity, so synchronized cardiovert just like before. So whether they're stable or unstable is going to determine medication. But if they're unstable, just electricity at the same levels. So if they're dead, asystole or pulseless electrical activity, ventricular fibrillation. We have pulseless ventricular tachycardia as well. So if they're in VFib, then they are shockable. Our 3 rhythms for shockability is going to be, and we call it fibrillate. So VTAC, VFib, what was the other one? Tombstones. VTAC, VFib. Could have sworn there's a third one. Defibrillate whenever it becomes available. We want to make sure we gain IV and IO access. Epinephrine, we want to give 1 milligram, 1 in 10,000, more potent, every 3 to 5 minutes for duration of the code. If they're in a refractory VFib or pulseless VTAC, then rhythm sustains after 2 fibrillations. I don't think that's what PVT is. Amiodarone, we're going to give 300 milligrams IV push. And make sure they remain, if they remain in refractory, we'll give another amount of amiodarone of 150 IV push. We're going to go through our H's and T's throughout cardiac arrest. So we're looking at things such as how cold are they? Are they hypothermic, hypoxemia, hypoglycemic, hyperkalemia, hypocalcemia, toxicities, cardiac tamponade, tension pneumothorax. So toxicity. I'm missing a few of those. Asystole, PEA. Oh shoot! Come on. Damn it! And that's why I'm broke. Where am I at? Epinephrine, 1 milligram, 1 in 10,000, 3 to 5 minutes for the duration of the code. H's and T's. Antidysrhythmic, so delays of conduction to the atrioventricular node, your AV node, used in stable supraventricular tachycardia, SVT, 6 milligram, 12 milligram, all the way, 18 milligram. May consider a second dose of 12 milligram up to 30 milligrams, so I have not seen that. That's new. Rapid IV push peripheral IV site. Also, when we give this, you want to give it in their AC. We want it to get to the heart before the half-life runs out on it. So what we'll do is we slam it. We'll hold their arm up like this so it can push it, and gravity helps us push it to the heart. So all those things are going to matter and come into play. Adenosine has a 10-second half-life, so you have 10 seconds to get to the heart. If they're in stable supraventricular tachycardia, vagal down, adenosine still. Other ACLS medications, so we have class 3 antidysrhythmic. This is going to block our potassium channel in the effective refractory period. Also blocks sodium channels and has some calcium channel blocking properties. So indication is recurrent ventricular fibrillation and pulseless ventricular tachycardia. 300 milligrams IV push the first dose, 150 milligrams IV push the second dose. Now, if they're in stable ventricular tachycardia with a pulse, we're going to give 150 milligram infused over 10 minutes minimal. And this is stable ventricular. So amiodarone 150 over 10 minutes, procainamide 25 over 50, and solutol 100 over 5 minutes. For VFib and pulseless, shockable, immediately begin CPR. Make sure you start compressions. Defibrillate when available, IV access, that's important so we can give medications, epi-ami. So epinephrine in refractory period, VFib, rhythm sustains after 2 fibrillations, amiodarone, H's and T's we're constantly monitoring. Antipyretic, antiplatelet aggregator, blocks the platelet aggregation, prevents platelets from sticking together, thus reduces risk of clots. You could get chest pain, acute coronary syndrome, ACS, and contraindications would be children with known hypersensitivity, activity ulcer disease, signs and history of stroke. Our dosage is 81 all the way up to 324, about 4 tablets. If a patient has taken aspirin in 24 hours, then we're going to give remaining tablets to total 324 milligrams, but we don't want to give more than that. We also have atropine sulfate. So this is a parasympatholic and anticholinergic that inhibits parasympathetic nervous system, acts on the vagus nerve and cranial nerve. So cranial nerve 10, vagus nerve, and cranial nerve 10. Yeah, cranial nerve 10. Used in symptomatic bradycardia. So if they have symptoms, 1 milligram, max of 3 milligrams, cumulative dose, and push rapid. If you do it too slow, it could cause refractory bradycardia, which is the reverse effect of what we want. Organophosphate poisoning, it's good for this because that's going to slow the heart down as well. 1 minute to control secretion. So sludge is salivation, lacrimation, What is U? Oh, urinary. D is, I don't know. If you're crapping, and emesis if you're throwing up. Everything that secretes fluids, your body is shoving all of the fluids out as much as it can. So salivation, lacrimation, I guess if you're sweating, diaphoresis, something like that. Sinus, and then gastrointestinal. Sinus bradycardia, junctional escape, second degree, type 1, atropine 1 milligram, up to a max of 3, transcutaneous pacing, 60 beats per minute AHA, yep, just like we talked about, 50 plus milliamps until mechanical pulse and electrical capture, and then give vasopressins. Dopamine, inotropin, endogenous catecholamine, so you have 0.5 to 2 micrograms per kilogram per minute, dopaminergic dose. It dilates renal and mesenteric arteries. 2 to 10 micrograms per kilogram per minute for a beta dose. Beta receptor stimulation, positive enotropy, chronotropy, and dromotropy. I know chronotropy is rate, enotropy is contractility, dromotropy, I can't remember what that one was. I'm trying to remember the Greek words. But depending on the amount that you give is going to determine what activity dopamine is going to act on you. So if you're giving more than 10 to 20 micrograms alpha dose, that means we're going to alpha receptor stimulation, vasoconstriction. It's going to constrict the veins. And typically it's going to be 1,600 micrograms per milliliter, 800 milligrams total. We'll stop there.